Good evening, sir.
Yeah, good evening. Good evening, Prashant. Good evening, everyone. You are all welcome to the 75 Diamond issue of our ENOCH DigiConnect webinar and the 40th Ruby episode of our COVID Epid update. That has been an untiring effort for last 75 weeks during this COVID pandemic. We had been working very hard, in very resilient ways to contact with and connect with our members and convey our regards, our respect, our support to each and every one of them. And now may I request our President, Dr. Gajen Kumar sir, to give the welcome address.
Good evening, friends. It is a proud moment today to welcome you all on our 75th Diamond Jubilee program of this webinar series, which we are holding for last now more than 1.5 years and since the start of this COVID-19. And with the efforts of our team, Team Delhi, we have been successfully doing this program, and I am so happy, and I compliment each one of us on this Golden Jubilee program, Diamond Jubilee program. As usual, we have got two speakers with us. The first topic of cardiac arrest is very, very important, which we have seen many cases, especially during COVID and post-COVID time. So I welcome both these speakers and I welcome all the participants. With these few words, I hand over to Dr. Sandeep for proceeding in the webinar. Thank you.
Thank you, Dr. Gajen Kumar sir, President of Delhi branch of IUH, that is AEOSD, Association of Environment and Occupation, Delhi. I welcome you all again on behalf of the AUSD and our association on this 75th Diamond issue of our ENOCH DigiConnect webinar and the 40th Ruby episode of our COVID Epid updates. So as I told you, Dr. Prashant Kumar Panda, actually this association is of Association of Occupational Physicians, Public Health Physicians, Industrial Doctors across India. And we have more than 3,000 members across India. And this particular program is being organized on a sustainable basis for last 1.5 years, as our president has already told you, that without a gap of even a single week, whether we have, we were engaged in so many activities in our professional life or our personal life. A lot of us, we have faced the tragedy of this second wave of the COVID, but still, despite all the tragedy and all the problems we had, we continued with this our episode, and it was all possible because of a team effort, and this was all because of we wanted to have learning for every one of us. We wanted to connect with every one of our members, and we never wanted they should be left alone, or we should be left alone during this COVID pandemic. So in these new norms, what we have decided, we started this ENOCH DigiConnect webinar platform, and this is the 75th issue of this particular episode, and we had more than 75 speakers from different faculties, renowned speakers who had come and deliberated with our members. And this particular program is live telecasted on our YouTube channel, that is ENOCH DigiConnect webinar, and we had created a repository of more than 95 videos on the YouTube, where our industrial physicians, our occupational physician, public health physician, they can go back and listen to what the experts have said. So this platform was basically created to learn from each other, and we have continued in our efforts, and we are continuing it despite all odds. And to all our members who have joined uh, today, Dr. Prashant Kumar Panda is our first speaker, and he is currently working as associate professor in cardiology, Department of Cardiology, from PGI Chandigarh. And Dr. Panda joined PGI in the year 2017. He did his MBBS from Maulana Azad Medical College. Again, a great compliment, because most of the panelists now, they are from Maulana Azad Medical College only. They are all your seniors, and he did his DM cardiology from PGI Chandigarh, and routinely performing diagnostic and therapeutic cardiovascular procedures, routinely performing PCI in STEMI and high-risk PCI and complex PCI, dual chamber and single chamber pacemakers, performed more than 50 PTMC, performed more than 100 CRT, and actively involved in lectures, seminars, workshops on intervention and diagnostic radiology. And he has published more than 47 research papers in national and international journals, including 7 original research, primary research interests in intervention cardiology and structural heart disease. So the topic, what we decided today, Dr. Panda, is the sudden cardiac arrest, because it is now a leading cause of death, sudden death in amongst our workers, amongst the population. And we want to know the latest developments which are there in managing this sudden cardiac arrest, how we can go about it, what are the guidelines, because we industrial physicians in this way we would be equipped with the knowledge, latest knowledge, so that we can take care of our workforce and guide our management accordingly. So, Dr. Panda, your floor is yours. You can start your presentation.
Thank you, sir. Thank you, sir, for for giving me the opportunity to speak in presence of such an eminent people. So the topic for today's discussion will be sudden cardiac arrest. So I will be sharing my screen. Sir, sudden cardiac death is defined as natural death from cardiac causes, and it is heralded by abrupt loss of consciousness within 1 hour of onset of acute symptoms. And pre-existing heart disease may or may not be known to be present at the time, and the mode of death is usually unexpected. The WHO defines sudden cardiac death as unexpected death within 1 hour of symptom onset if witnessed, or within 24 hours of person having been observed alive and symptom free if unwitnessed. So the sudden cardiac death from cardiac cause is estimated to account for approximately 50% causes of all deaths from cardiovascular causes. The majority of sudden deaths are caused by acute ventricular arrhythmias, often triggered by acute coronary syndrome, which occur in persons without cardiac disease or in association with structural heart disease. So this is the distribution of sudden cardiac death. What we can see is the incidence of sudden cardiac death in general population is low, but the number of, if we look by the numbers, the number of sudden cardiac death in general population is very high. And the incidence of sudden cardiac death in the very high risk patients, like those patients who have lower ejection fraction, who have documented non-sustained ventricular tachycardia or documented ventricular tachycardia, the incidence of sudden cardiac death is around 30% in such population. Though in numbers, if we see, they are very less than as in general population. So many of time we have heard that players, they die suddenly in the field. So basically, for sudden cardiac death in competitive athletes, it is divided into two age groups, that is less than 35-year age group and more than 35 year of age group. In less than 35 years of age group, hypertrophic cardiomyopathy is the most common cause of sudden cardiac death. And the second leading cause is idiopathic LVH, and idiopathic LVH leading to ventricular tachycardia and ventricular fibrillation. These are the two major causes of sudden cardiac death in competitive athletes. So even in industrialized countries, in developed countries, it is a prerequisite to have a pre-competitive ECG to rule out hypertrophic cardiomyopathy. Because in most of the patients with HOCM, by simple doing an electrocardiogram, we can rule out whether the person is having HCM or not. In athletes who are more than 35 years of age, as in general population, the most common cause of sudden death is coronary artery disease. And other causes like valvular heart disease, hypertrophic cardiomyopathy, mitral valve prolapse, and unexplained, these are lesser known cause for sudden cardiac death. 80% of these sudden cardiac death are because of coronary heart disease. So in most of the times, the sudden cardiac death is because of arrhythmia, that is around 90% are because of arrhythmic cause, and 12% causes of sudden cardiac death are because of other causes. And among the 90% causes of arrhythmic death, 62% are because of ventricular tachycardia, monomorphic ventricular tachycardia degenerating into ventricular fibrillation. Rest causes are polymorphic VT bradycardia. So in patients with arrhythmia and sudden cardiac death, the usual symptoms are palpitation, dyspnea, chest pain, syncope, presyncope, and patient can also present with sudden cardiac arrest without symptoms if the patient have asystole, that is sinus arrest, AB block, ventricular fibrillation, and also pulseless electrical activity. So the symptoms are different if patient has MI and if a patient has sudden cardiac arrest. These two have different symptoms, because MI is because of coronary artery obstruction, which will lead to chest pain, radiation of pain to the shoulders, nausea, vomiting, shortness of breath, palpitation. While in sudden cardiac arrest, the patients have sudden collapse and loss of consciousness. There is cessation of normal breathing, and there is loss of pulse and blood pressure. So the burden of sudden cardiac, the prevalence of sudden cardiac death, it is the most common and often the first manifestation of CAD. Though we are seeing many patients in OPD, but usually in asymptomatic patients, the first presentation of manifestation of coronary artery disease will be sudden cardiac death. In what we know about is around 25% of MI patients, they do not present to the hospital. They will have sudden cardiac death because of VT and VF. Secondly, the sudden cardiac death accounts for, because we don't have any conclusive Indian data regarding the prevalence of sudden cardiac death. Whatever data we have from the developed countries, and we have extrapolated the data from these countries to India. So sudden cardiac death, it accounts for around 3 to 4 lakhs annually in United States, and annual incidence is around 0.36 to 1.8 in general population. And it is supposedly it is said that the sudden cardiac death rate in developing countries is lower, though we do not have any conclusive study. So this chart shows that in US, around 20% of all deaths are because of the sudden cardiac arrest, which is around 450,000 deaths per year. And of all cardiac causes, 60% of all cardiac deaths are because of sudden cardiac arrest or arrhythmic deaths. The annual incidence in general population is around 0.1%. So the most of the sudden cardiac deaths occurs in general population without a known history of heart disease. And in autopsies, it has shown that 90% of the patients with sudden cardiac death have structural heart disease. And it is the first presentation in around 85 to 90% of the disease. And in 10 to 15%, it is because of recurrent event. And 80% of the sudden cardiac death, they occur out of the hospital setting. And 40% of the sudden cardiac arrest, they occur during sleep or they are not witnessed by anyone. Only 5% of there is the survival rate of out of cardiac arrest is only around 5% in developed countries like US. In the management of sudden cardiac arrest, time is the key. If the duration of giving successful CPR, it goes beyond 10 minutes, the chance of survival reduces. So every minute, there are chances of the chances of success are reduced by 7 to 10%. So if we start CPR whenever a patient has developed sudden cardiac arrest, if we start CPR, the chances of survival are still there. But if 10 minutes beyond the onset of sudden cardiac arrest, the chances of survival becomes very low. So for management of sudden cardiac arrest, these are the basic survival chain, that is early access. There should be early contact to the emergency team. Then early CPR should be started. Then if the rhythm is shockable, then early defibrillation should be given. Then the early advanced care is given to the patient, and later on the patient is evaluated for the need of whether there is any need for intracardiac defibrillator or not. So we have extrapolated the data from United States in India, and from the extrapolation we can see that in India around 3 lakh deaths in India are because of around 1.5 lakh of total cardiac deaths are because of sudden cardiac arrest. And it is around this is only the extrapolation. We do not have any exact data, since we do not have any population based studies ascertaining the incidence of sudden cardiac death. The mechanism of sudden cardiac arrest is bradycardia. It can cause torsades leading to VF. Bradycardia assistally rarely cause sudden cardiac death except in patients with end-stage heart failure, that is NYHA class 4. And in these patients, cardiac pacing will not help in the revival of the patient. Then the other rhythms which are seen in patients with cardiac arrest includes ventricular fibrillation. And if there is VF, then we have to start CPR and we have to give defibrillation shock. If patient has pulseless VT, then we have to start CPR and give defibrillation. If patient has asystole, then defibrillation has no role, so we have to start CPR and epinephrine and atropine. These has to be given. And also in pulseless bradycardia, we have to start CPR and we have to give epinephrine atropine. In pulseless electrical activity, usually the heart will not respond to any electrical stimulation, like if you start pacing or if you give shock, there will be no response from the cardiac muscles. So this is the etiology of sudden cardiac death, in which most of 80% of the time the SCD is because of the coronary artery disease. So these are the etiology of sudden cardiac death, in which 80% is because of CAD. Then 10 to 15% these are because of ischemic cardiomyopathy, dilated cardiomyopathy. Then the other important causes are hypertrophic cardiomyopathy, and rare causes are arrhythmogenic right ventricular cardiomyopathy, ion channel related disorders, long QT syndrome. These are all electrophysiological causes of sudden cardiac death. So I have already discussed that in 90% of the patients with sudden cardiac death who have shockable rhythm, around 60% will have monomorphic VT. So monomorphic DT is due to electrical re-entry or polymorphic VT, and it is because of the presence of scar tissue or fibrosis because of the previous myocardial infarction or previous scarring. And these are uniform wavefront, and the propagation is prevented. And this facilitator for the onset of ventricular fibrillation or ventricular tachycardia in a patient with sudden cardiac arrest is facilitated by presence of PVCs, ventricular premature complexes. If there is evidence, if there is ischemia, if there are any electrolyte abnormalities, and in case of sympathetic excitation, vagal excitation, and some drugs, they can also prolong QT and they can lead to ventricular tachycardia and ventricular fibrillation. So for sudden cardiac death, we have substrate, and the substrate is CAD, patients with cardiomyopathy, right ventricular dysplasia, valvular heart disease, congenital heart disease, electrical disorders. Then we have events which trigger the onset of sudden cardiac arrest. These include neuroendocrine causes, drugs, electrolytes, ischemia, hemodynamics alteration, and stress, like when patient is arising from sleep, then alcohol. These are all the triggers trigger for sudden cardiac arrest. And the mechanism for these are re-entry. Mechanism for onset of ventricular tachycardia, ventricular fibrillation is re-entry, automaticity, triggered activity, and cell-to-cell uncoupling. These all lead to a common mechanism, that is electromechanical dissociation, asystole, ventricular tachycardia, and ventricular fibrillation. So we have inciting agents like drug, electrical activity, neurohormonal alterations, electrolyte imbalance, acidosis, which in presence of substrate like chronic fibrosis, infarction, hypertrophy, they lead to the ventricular tachycardia and ventricular fibrillation. So we are interested in knowing which are the patients who are at the risk of sudden cardiac death. Though from the prevalence data, we can see that most of the sudden cardiac death, it occurs in general population. by the number, if we look at the numbers of patients with sudden cardiac death, but the prevalence is higher in patients who have evidence of prior evidence of sudden cardiac death, or prior evidence of if they have a history of low ejection fraction. So these are the subset of patients who have high incidence of sudden cardiac death. So for general population, how we can screen? So these are the variables which we can see in a patient if they have any increased risk for death from sudden cardiac death. So the conventional risk factors, since 80% of the sudden cardiac death is because of CAD, so the CAD risk factors are very important in determining whether a person can have increased risk of sudden death. These includes conventional risk factors like high cholesterol, blood pressure, smoking, and diabetes. But they have low power to discriminate, because these will be in a general population, a higher proportion of patients, they will be having these risk factors. So control of this risk factor in a general population at a general level will lead to the decreased incidence of sudden cardiac death. Other markers are NYHA functional class and ejection fraction. Till now, these are the only two marker which has high predictive value for sudden cardiac death in patient if they have lower ejection fraction, if they have a higher NYHA functional class. Then we have other markers like ambient ventricular arrhythmias. If on a Holter recording, patient has evidence of frequent premature ventricular complex, evidence of non-sustained VT and sustained VT. So these are the transient triggers. In presence of LV dysfunction, these are markers for the risk of sudden cardiac death. Then we have ECG variables. ECG variables will help in differentiating whether patient is having disorders like hypertrophic cardiomyopathy, arrhythmogenic right ventricular tachycardia, Brugada syndrome. So these markers on a standard ECG routine screening ECG, they can predict the risk of sudden cardiac death. Then we have other newer markers, like we have late potential on signal average ECG. Though these are they have high negative predictive value, but if they are absent, the chance of sudden cardiac death is less. But their presence doesn't signify that the person has high risk of sudden cardiac death. Then we have other markers of autonomic nervous dysfunction like heart rate variability, baroreflex sensitivity. But these they have not been shown to have a accurate predictive value in neither in the general population or neither in patients with underlying structural heart disease. So for in patients with, if we want to have ascertain the risk of sudden cardiac death, these are the tests which can be performed. These are tests for knowing the coronary perfusion, like coronary angiogram, exercise testing, ST segment changes during 24-hour Holter. They are also marker of ischemia, and they also predict sudden cardiac death. Then we can assess the LV function by NYHA functional class, ejection fraction, and exercise duration on TMT. Then on 24-hour Holter monitoring, these can also tell about the risk of sudden cardiac death, like signal average ECG, QT interval, duration, dispersion, dynamic changes, T-wave alterance, exercise testing, and program electrical stimulation. Then heart rate variability, baroreflex sensitivity, they can have add-on value in predicting the risk of sudden cardiac death. Depression is also a major risk factor for sudden cardiac death. So historically, who are the patients who are at the risk of increased risk of sudden cardiac death? So we have one Epid registry. This was a registry for secondary prevention of patients with sudden cardiac death. In this, it was shown that in patients who are more than 65 years of age, who have history of congestive heart failure, who have history of atrial fibrillation, smoking, diabetes, reduced ejection fraction, and history of pacemaker, these patients, they have high incidence of sudden cardiac death. So history can provide us a clue that who are the patients in patients with VT after MI, if they have syncope at the time of first documented episode of arrhythmia, and if they have higher functional class like NYHA class 3-4, if they have ventricular tachycardia fibrillation from 3 days to 2 months. Up to 3 days, this is primary ventricular fibrillation. This will not have any implication on the risk of sudden cardiac death, but beyond 3 days, if a patient has VTVF, then they are at the risk of increased risk of sudden cardiac death. And usually this occurs in patients who have extensive MI and who have poor LV function. And also in patients who have repeated history of MI, they are at the high risk of developing sudden cardiac death. Secondly, the QRS duration and repolarization abnormalities are the independent predictor of sudden cardiac death. So QRS duration and repolarization, QRS duration more than 120 to 130, even in patients with normal, in normal population also, this prolonged duration predicts the risk of sudden cardiac death. And more so in patients who have ejection fraction less than 30%, this wide QRS has a good predictive value for the risk of sudden cardiac death. of all the markers, only 2 markers which have been found to have a predictive value of sudden cardiac death are ejection fraction. In LV dysfunction, it is major independent predictor of sudden cardiac mortality in patients with both ischemic and non-ischemic cardiomyopathy. In survivors of cardiac arrest, LVF 30% or less, sudden cardiac death of more than 30%. The incidence of sudden cardiac death is around 30% over 1 to 3 years. And in 15 to 50% in those who have inducible VT, the drugs that suppress inducible arrhythmias were an empirical therapy in this Epid study. So LVF predicts total cardiac mortality, and it will not differentiate between sudden cardiac death, but these are the patients who will have high incidence of sudden cardiac death. So in patients who are sudden survivor of sudden cardiac death, they have 1 year risk of around 50% risk of again succumbing to this sudden cardiac death. In patients who have VT with syncope or VT with ejection fraction of less than 40%, they are also at the high risk of developing sudden cardiac death. In patients who have VT which is hemodynamically tolerated, they are at a lower risk, but still they have a 20 to 30% chances of dying from sudden cardiac death. So we have some few trials which have seen which have documented that in patients with documented VT, if we implant intracardiac defibrillator, they have a good survival. Of these, the major trial were Epid, SEEDS, and CASH. This was done in patients with prior evidence of sudden cardiac death. All these trials have shown that, as compared to drugs that was Cartron, if a patient has implantation of intracardiac defibrillator, they have a better chance of survival. So these 3 trials, they were all trials in which ICD was compared with amiodarone therapy in patients who have already sustained VT or VT and VF, and all those patients who belong to high risk group. In all these patients, they included patients with sudden cardiac death, non-tolerated VT, and tolerated VT. The maximum benefit was seen in those patients who were survivor of VT or who have symptomatic ventricular tachycardia. So because of these trials, this is class 1 indication. The AHA has given is class 1 indication for implantation of ICD therapy in cardiac arrest due to VT or VF, not due to transient or reversible causes. If you rule out the transient and reversible causes, then this is class 1 indication. And secondly, the second cause is spontaneously sustained VT in presence of any structural heart disease. Also, ICD therapy is indicated in patients. This was also updated in ACC 2008 guideline. ICD therapy is indicated in patients who are survivor of cardiac arrest due to ventricular fibrillation or hemodynamically unstable VT after evaluation to define the cause of event and to exclude any reversible causes. And similarly, ICD therapy is indicated in patients with structural heart disease and spontaneous VT, whether hemodynamically stable or unstable, though the level of evidence is 1B here. So if a patient has cardiac arrest and then it is a class 1 indication in presence of LV dysfunction. This is a class 1 indication. And if a patient has sustained VT and a patient has a history of a reduced ejection fraction, then this is also class 1 indication. Also, in many of times, patients with LV dysfunction, they have syncope, but we are not able to determine the cause of syncope. It was also found in these studies that patients with LV dysfunction and unexplained syncope, they have also have high mortality rate similar to a patient resuscitated from cardiac arrest. So these are also the patients who will benefit from ICD implantation. In second high risk group is the patients who have low EF and in post MI, if a patient has persistence low EF, these are also the group of patients who have high risk of sudden cardiac death. So this is only EF ejection fraction is the single important risk factor for overall mortality and sudden cardiac death in patients in post MI state. Post MI also analysis of mortality rate in control group of clinical studies in post MI with LV dysfunction has shown that overall mortality is around 20 to 30% at 2 years, with most of the deaths is because of sudden cardiac death and rest of the deaths are due to pump failure. So this is the chart showing the mortality rate in various trials in which they have recruited post MI patients with LV dysfunction. So the total arrhythmic death is more in patients who have MI and LV dysfunction. So, and secondly, the most important thing is the patients who are less symptomatic, they have high chance of sudden cardiac death. Like in patients with NYHA class 2, 3, in class 1 and class 2 patients, they have high chance of sudden cardiac death and less chance of pump failure. While patients who are in class 3, class 4 state, they have high chances of death due to pump failure and less chances of developing sudden cardiac death. So as NYHA class increases, the chance of sudden death decreases, while a patient with lower NYHA class, they have the mortality is the chances of mortality with sudden cardiac death is more. So these were the trials, landmark trials in post-MI patients who have tried ICD therapy with antiarrhythmic therapies. So at high risk, these are the primary prevention trials. They were at high risk of sudden cardiac death due to VTVF, and they have not yet experienced sustained VT. So patients who had previous MI, low EF, and inducible VT during EP study, they were divided into ICD therapy with conventional therapy with drugs. These trials included MEDIT, MUST, MEDIT2, and SCD-HEFT. So all these patients, they included MI patients with LV dysfunction, and few of the trials, they included other markers like presence of NSVT on Holter,
It's 7 o'clock.
Presence of inducible ventricular tachycardia on electrophysiological study, and inducible non-suppressible VT on electrophysiological study. All these trials, MEDIT2 were the largest trial. In MEDIT2, they have only included patients with MI and LV dysfunction without any presence of these high-risk markers. And these all trials, they have shown that drugs have a limited role in reducing death due to sudden cardiac arrest in heart failure patients and post-MI patients with low ejection fraction. So now, if post 40 days MI, if a patient has ejection fraction of 30 to 40%, in ICD is indicated as primary prevention. While in non-ischemic heart disease, in patients who have ejection fraction of 30-35%, and they are in NYHA class 2, 3, the class 4 patients are not included in this because they have high chances of death from pump failure. They have class 1 indication for ICD implantation. So MEDIT was the largest trial which hypothesized that ICD will reduce mortality in high-risk CAD patients. So it included patients with prior MI, sustained VT, ejection fraction less than 35, inducible VT, and NYHA class 1 to 3. Age was around from 25 to 80 years and more than 3 weeks from last MI. It was not required whether patient was having underwent revascularization or not. All patients were included. So MEDIT1 was a small trial which included around 106 patients, in which ICD therapy, conventional therapy was given to 101 and ICD was given to 96 patients, and mean follow-up was up to 32 months. So it was in MEDIT, their conclusion was that ICD prophylactic therapy with ICD lead to improved survival as compared to conventional medical therapy. In MEDIT2, which is the largest trial and all the guidelines are based on MEDIT2 trial, it included patients with MI more than 4 weeks, ejection fraction less than 30%, more than 20 years of age, and there was no requirement of documentation of other risk factors like non-sustained VT or electrophysiological documentation of ventricular tachycardia. It excluded patients with ICD who have indication for ICD other than this, and who were NYHA class at enrollment, who had undergone CABG less than 3 months, MI less than 1 month, and advanced cerebrovascular disease, and high likelihood of death during trial. These patients were included in this trial. So this trial also showed that as compared to conventional therapy, patients with defibrillator, they have a good survival, they have less chances of dying. So it was concluded that ICD therapy significantly reduced the incidence of overmortality by 31%, and it proved significant among patients who were on optimal drug therapy. Then we have trials in which the SCD-HEFT trial was done in patients with both ischemic and non-ischemic cardiomyopathy with ejection fraction less than 35. It was divided into 3 groups, and patients were one was placebo group, one was patient who had medical therapy with cardaron, amiodarone, and third group was patients who underwent ICD implantation. This also showed that patients with ICD, irrespective of the cause of cardiomyopathy, that is ischemic and non-ischemic, they have better survival as compared to conventional medical therapy. So this was the survival rate, overall survival rate at the in this trial. So what we see is in ICD, the incidence of tachyarrhythmias was reduced in patients who have ICD, while the rest of heart failure due to death due to pump failure, non-arrhythmic causes by bradyarrhythmia, these causes were similar in all the three groups. So because of ICD therapy reduced tachyarrhythmic deaths by around 60% in patients with non-ischemic or ischemic cardiomyopathy. So because of this, the ICD for primary prevention was given a class 1 recommendation, and it is recommended in patients with NYHA class 2 or 3 with a history of MI with ejection fraction less than 35%, in patients with class 2, class 3 non-ischemic cardiomyopathy with ejection fraction less than 35%, in patients class 1 patients who have prior MI and ejection fraction less than 30%. So ICD mortality reduction, normal notion is that if a patient, we are giving ICD for a primary prevention, the risk will be, we have to treat a larger number of patients to get the benefit. But overall, in a meta-analysis, it was shown that ICD mortality reduction in primary prevention trial is equal to or greater than in those within secondary prevention trials. Second important cause in general population of sudden cardiac death is hypertrophic cardiomyopathy in young people. So in also hypertrophic cardiomyopathy, the cause of sudden death is the incidence of the death, mode of death is because of sudden death, because of arrhythmic death, secondly pump failure because of heart failure, and third is stroke. So usually patients with HCM, they have usually no or mild symptoms. They are the SCD event, they occur while patients are sedentary or with mild physical exertion, and they may occur at any age. But with increasing age, the chance of sudden cardiac death decreases and the risk of death due to pump failure increases. So this is the chart showing mortality in patients with HCM as divided according to the age. What we can see is in younger patients, the chance of sudden death is high, but as age increases, the chance of sudden death decreases and mortality due to heart failure and stroke increases. And second predictor of sudden cardiac death in HCM patients is left ventricular wall thickness. If the thickness is more than 30 millimeter, then these are the high risk patients who have high risk of death due to sudden cardiac death. So in patients with HCM, we usually ICD implantation is indicated in those patients who have highest risk of sudden cardiac death. So these are patients who have history of prior cardiac arrest, sustained VT, who have family history of sudden death, who have on genotypic testing, there are few genotypes which are prone for sudden cardiac death. If patients have recurrent syncope, and if there is evidence of multiple repeated non-sustained VT on a Holter, and if there is either hypotension or there is no increase in the blood pressure on exercise TMT, and massive LVH on echo. These are the markers for high risk, markers which signify high risk in patients with hypertrophic cardiomyopathy. And in patients, in HCM patients, ICD is highly effective in terminating life-threatening ventricular tachyarrhythmias, often in young patients with few or no symptoms. And it has demonstrated a life-saving role both for secondary prevention, that is those patients who have aborted cardiac arrest or sustained VT, and also it has prophylactic primary prevention of sudden death in patients who have high risk based on their clinical profile. And it has demonstrated primary VTVF to be the principal mechanism of sudden death, especially in the younger population. So, sir, in conclusion, the risk factors for sudden cardiac, though the incidence of sudden cardiac death in general population is because of CAD, and ultimately for decreasing the incidence of CAD, we have to adequately control the coronary artery disease risk factor. But the risk factors are survivor of patients who have the sudden cardiac death due to ventricular fibrillation, if patients who have prior episodes of VT, these are the most high risk patients. These are the high risk people. They will have recurrence of, they can have recurrence of sudden cardiac death. Thirdly, patients who have previous myocardial infarction, who have lower ejection fraction, who patients with non-ischemic cardiomyopathy and heart failure. If a patient has history of sudden cardiac death, then they need evaluation for ruling out channelopathies like long QT syndrome, ARVD. These are all genetic disorders. Then also if a patient has ventricular hypertrophy and hypertrophic cardiomyopathy, long QT syndrome, arrhythmogenic right ventricular dysplasia, Brugada syndrome. These are all risk factors. The presence of these risk factors, they will tell whether a person is going to have a high chance of sudden cardiac death or not. So if the highest risk factor of sudden cardiac death are those patients who have already survived a sudden cardiac event. Then if a patient has ventricular tachycardia with syncope, that is symptomatic VT, The third will be patients who have ventricular tachycardia, though without symptoms, but ejection fraction less than 40%. Then we have patients with normal structural heart with ventricular tachycardia with minimal symptom. They are at a lesser risk. And also, those patients who have not evidenced VT, that is patients with previous MI and on non-sustained VT and ejection fraction less than 35%. These are the patients who are at high risk of developing sudden cardiac death. So this is the same chart showing that these are the high risk patients. So the highest clinical risk factor for sudden cardiac death includes patients with low ejection fraction, patients with coronary artery disease prior MI, patients with dilated cardiomyopathy and heart failure symptoms due to CAD, and also because of non-ischemic cardiomyopathy without evidence of coronary artery disease, patients who have resuscitation from prior ventricular tachycardia, ventricular fibrillation, patients who have genetic factors like hypertrophic cardiomyopathy, long QT, ARVT, Brugada, though these are very less in the general population. Any combination of these risk factors, this increases the risk of sudden cardiac death.
So, thank you, Dr. Prashant. You have given a very nice, comprehensive overview of the sudden cardiac death, how to identify the risk factors, do the risk stratification, and especially since we are all physician, industrial physician from industries, we need to be more knowledgeable about the preventive factors and what are the risk factors which causes sudden cardiac death. So as you rightly told, that arrhythmia, ventricular tachycardia, and this hypertrophic cardiomyopathy, all these, and low ejection fractions, all these parameters, they need to be watched by every one of us during the periodic medical examination of our patients. And we have to watch for the symptoms, watch for the clinical history of the patient. And as these sudden cardiac death, 80% of them, they occur outside the hospital. So so we need to educate the people about what are the risk factors and how to take care in case of an event. Then chain of events that we have to follow, like early CPR, early defibrillation. And I would again like to ask you, Dr. Prashant, I would like to elaborate you to elaborate on that slide, which was, I think, 6th or 7th slide. In case of a sudden cardiac patient who suddenly collapses, and we find that either he is in ventricular tachycardia or he is pulseless, or what are the different scenarios in which what treatment we have to start initially, because otherwise what happens, CPR we have to start, but whether defibrillation is important or not, when to give atropine, when to give this medication, so that is important. I would like to you to elaborate that particular slide, which is very important for every one of us in case of emergency. Yeah.
Yes, sir. The first thing, whenever a patient has a sudden cardiac death, the first thing is to ascertain look at the ECG, sir. If ECG has, I'm just.
No, but ECG will take time, and as most of these collapses, they occur outside the hospital.
Yes.
So as a layman, as a first aider, what we are supposed to do?
Sir, as a layman, sir, we have in United States and even in India, sir, we can in many airports we can see we have defibrillator in the for general public also, because sir, most of the time if a patient falls suddenly, has a sudden cardiac death at a public place, we have to assume that this is because of ventricular tachycardia. So there is no harm in giving a shock, sir. If a patient suddenly collapses and we are not able to find the pulse, then there is no harm in giving a shock, sir, if we have this defibrillator available. But if defibrillator is not available, then we have many trials we have shown that only CPR only resuscitation is also effective, sir. Without doing anything, if we start chest compression, this is also effective. This will decrease the time to successful onset of circulation, sir. This will help in the earlier start of the circulation. So if a patient collapses suddenly where we don't have any available facilities for getting the ECG, then chest only compression only CPR is also effective. Secondly, whatever the rhythm is there, we can give a shock, sir. There is no harm in giving a defibrillator shock.
Then there is one. Are there any guidelines, Indian guidelines for the placement of the defibrillators? Because as per international guidelines, if the medical facilities are not available within 5 minutes of the place where the patient has collapsed, then in that case we have to install a defibrillator over there. So
Sir, we don't have guideline, but because the incidence of sudden cardiac death in India is not as high as compared to Western countries, so what they have done, they have for in all the like airports, stadiums, they will have a portable defibrillator. That is very easy to both the leads you can place over the chest and you can give a shock.
and in case of offices,
Offices are in like sir in places where you work, like sir big industries, sir, there should be a recommendation for implantation of at least portable defibrillator. They are very cheap, they are chargeable, they will not give you the rhythm, they will give only the shock. That is different from a conventional defibrillator where where by putting the paddles we can see the ECG.
In case we have multi-story office, then we should have defibrillator on all the floors or one floor.
So that will depend upon the incidence. If we have high numbers of over a period of year, if you see that there are high number of people having sudden cardiac death, then in such scenario you can have this defibrillator at every floor. Otherwise, it is not recommended in places where there is no overcrowding. This is usually recommended for overcrowding public places where we have large number of people.
Okay, actually, these are the queries from the management side. Whenever we ask for a defibrillator in our premises, then these are the queries for any guidelines if you have. So thank you very much for the clarification. Now, Dr. Rajendra Kumar sir, he has got some query.
First of all, I congratulate Dr. Prashant for a wonderful presentation on this subject. Dr. Prashant, I am from NMC, 1974 admission.
Okay, sir.
Pretty senior, seems to be pretty senior. Okay, anyway, see, I got two questions with you. In the list of the high risk, nowhere you have mentioned hypertension as one of the risk factors. So
Sir,
is it?
Sir, it is a risk factor, but these are the CAD risk factors. They will not directly lead to sudden death, sir. They will all lead to sudden death by causing coronary artery disease, by causing MI. So, sir, but in the chart I have given that these risk factors at a general population level, these risk factors, they have to be controlled if you want to decrease the incidence of sudden cardiac death, sir.
Another about the point raised by Dr. Sandeep Sharma, you have very clearly told that even in USA, outside hospitals, sudden cardiac death has only 5% survival. And
Yes.
that too in the, I mean, if the availability of defibrillator and other things are available. In Indian scenario, even if I see, I work in the railways. I am chief consultant with the Northern Railway. In railways, at most of the major stations, we have put this defibrillator, and these are placed with the medical first aid kits in the station master's rooms. All stations, most of the major stations. But now the key, because this is an expensive equipment costing few thousand rupees. Now the key of this instrument is with somebody or somewhere. And suppose anything happens, I am very sure that within 5 minutes, nobody can fetch that equipment and reach to the place. Because if you see the New Delhi railway station, the total length is more than 1 kilometer and width is more than half a kilometer. There are 16 platforms. So there is no point anybody can pick it up and rush to the person. So the only solution left is CPR, which anybody who is around and who knows basic of first aid, he can provide this CPR. So as far as this defibrillators are concerned, we have provided to our health units and to so many places. But end of the day, what I am finding, after a certain time gap, most of the defibrillators were never charged. So their battery has been exhausted or lead has been spoiled or something has gone waste. So ultimately this whole investment of thousands of defibrillators, there was hardly any use, let me tell you. Very frankly, let me tell you. Because in America, if it is less than 5% outside hospital, I am sure that India, it cannot be better than that. Right? So I think I need your remarks on this as well.
Sir, the defibrillator which are kept in the public places in US, they are to be used by layman, sir. If we cannot expect a medic to pick up that defibrillator and go to the site and give a shock. So what they do for, sir, they have a few counties are there in US. They have very well developed program for prevention of sudden cardiac death. Because in this winter season, in these developed countries, they have high incidence of sudden cardiac death. So they have made a chain of they have made a chain to improve the survival, in which now one step more, that is this is therapeutic hypothermia. Whenever a patient with sudden cardiac death arrives, even if the cardiac activity comes, they don't, because of the decreased cerebral perfusion, they will go into brain dead state. So whenever a patient arrives, they will give therapeutic hypothermia. But I do not, these are only possible if we educate the layman, that if you experience a sudden cardiac death nearby you, and if you start only, even if defibrillator is not available, if you give chest only compression. So sir, these things have to be done at a population level. We cannot expect in a big railway station that single defibrillator and a single medicated duty every time to that to pick up that defibrillator and go to that person. So the key is here to educate the layman for the usage of these devices.
And one small question. See, we have got a system of periodic medical examination of employees. So my question is, if in the this examination somebody is considered to be a high risk person, is there any preventive role of amiodarone for such people?
Sir, this is very common scenario which we encounter, because sir, we read so much about ICD and all these things, but these are all costly therapy, which we cannot use this in a routine basis. Every patient is not a candidate. Every patient will not afford this. So sir, definitely in high risk patients, even today, sir, we write commonly cardarone, but these amiodarone. But these high risk patients are those who have evidence of dilated cardiomyopathy or ischemic cardiomyopathy, or they have evidence of ventricular tachycardia on Holter monitoring. So these, sir, in place of ICD, we can start them on cardarone. But prophylactic cardarone, that has a very negligible role. But for secondary prevention, if we know that this is a very high risk patient with LV dysfunction, with prior history of prior syncope, prior MI, then we can definitely start, sir. The only the shortcoming is that long-term cardarone has its own limitations, like toxicity, thyroid toxicity. So we have to corneal toxicity. If we can routinely monitor all these risk factors, then there is no harm in giving this.
Right. Thank you very much. Thank you.
Now the second question is from Dr. Rajiv Kumar Jain.
Good evening, Dr. Prashant. I'm also a fellow Mulani.
Yes, sir.
I would like to get your views on 3 issues which I feel need attention by cardiologists and physicians in general in India. If you remember, in 2016, American Heart Association brought out 10 quality and performance measures. Out of these 10, I would like to get your comments and action plan for implementation in India. One is smoking cessation intervention in patients who suffered sudden cardiac arrest, who have a life-threatening ventricular arrhythmia, or are at risk for sudden cardiac death. That's one. Second is referring for CPR and AED education, those family members of patients who are hospitalized with known heart conditions that increase the risk of sudden cardiac arrest. That's second. The third one is equally important. Counseling first-degree relatives of survivors of sudden cardiac arrest associated with an inheritable condition about the need for screening for the inheritable condition. These are the 3. I have a concern that we physicians, as well as cardiologists in particular, whether they are in teaching institutions or in non-teaching institutions, they need to give specific attention in India. And these are actionable issues. And American Heart Association has found these 10 as the most important quality and performance indicators. Now, where are we in India?
Yes, sir. The points that you have highlighted, they are very important. Like smoking, even if a patient, many of time patient think that I'm already on drugs. This is not going to harm me more. But in every aspect, we have seen that smoking cessation at any step, it will help the patient in increasing the longevity and increasing the survival. So it is most of the time we have a smoking cessation clinic. When patients, they are not able to quit smoking, we refer them routinely for add-on drugs and all psychological therapy to help them in the cessation of smoking. Secondly, sir, the point you highlighted, that education of the family members. If a patient has a heart disease, then the most important thing is the education of the family member regarding CPR. And if patient is very high risk, then they can also buy this automated IEDs, which are only they can give only shock. They can be bought by the patients who have very high risk for sudden cardiac death. So that these are the very important, I think, amendments which will help in the further reduction of sudden cardiac death in the general population. And we routinely do genetic screening with this genetic disorder. We routinely do genetic screening. We do ecos, like in patients with hypertrophic cardiomyopathy. We do routinely screening to see, because if this is a genetic disorder, and over the period, if at the initial screening they don't have evidence of hypertrophic cardiomyopathy, at follow-up also we do the echocardiography of the. It is recommended. I think this is being done everywhere, that relatives are being screened for evidence of hypertrophic cardiomyopathy.
Well, the practice I found on the ground is not that perfect, or there is a lot to be desired in terms of follow-up and how effective the education regarding CPR and AD, as well as effectiveness of counseling for smoking cessation is I have. And remember, I was in fact always have been noticing this. Amongst the 10 intervention quality indicators of American Heart Association, anti-smoking cessation is the number 1 out of the 10. And that is the weakest link, I believe. And I found people with having gone with very low ejection fraction still continuing to smoke, just because they've not been given a full regimen of smoking cessation, which can actually sustain the process of cessation.
So other than, I think, counseling, the most important part is drugs. So we have we have SSRIs like bupropion, and these are other drugs which can help in the smoking cessation. Because only counseling, most of the time, only I think less than 50% they are able to leave smoking with only counseling only. So I think they need drugs also, so that will help them in the smoking cessation on a longer run. And also, sir, what you said is rightly, that every time physician, cardiologist, they should reinforce the importance of smoking cessation.
Thank you so much. Thank you.
Thank you. Now the question, Dr. Tyagras from Bangalore, he has raised his hand, sir. Dr. Tyagras, sir.
Good evening. At the outset, it gives me great pleasure to congratulate AEOST team for organizing this 75th issue of ENOCH DigiConnect webinar and 40th Ruby episode of COVID updates. During this 75th year of India's independence celebration of Azadi Ka Mahotsav, it is great and sustained effort by Dr. Gajendra, Dr. Sandeep Sharma ji. Congratulations, my hearty congratulations. Thank you very much. And please keep it up and continue these programs. At the outset, thank you, Dr. Panda, for your wonderful presentation. It is really, you have covered everything. It is really a benchmark, roadmap, or landmark, everything you have covered such a beautifully. All the risk factors you have highlighted, some of the risk factors also, and for both highly educated people also for the layman also, how to this sudden cardiac arrest, how to prevent this sudden cardiac arrest. This also you have enlightened very nicely. I have a very fundamental, very small question. Whenever we are on duty, we get a cases of this sudden cardiac arrest. When we see these people, they have already passed, means death has already occurred. Now, the problem is whether these people sudden cardiac arrest has occurred due to ischemic heart disease or due to arrhythmia, because both are a different entity. So how to, in a by giving the death sheet, we have to mention this sudden cardiac arrest or myocardial infarction, whether it is due to ischemic heart disease or whether due to it has occurred due to arrhythmia or ventricular fibrillation. This one, it's a very confusing time because the patient has already died. You cannot take ECG, and the history also we may not get because some of them are young and energetic people of 35 to 40 years. They come with this kind of problem. I think will you please highlight what exactly how to write this death certificate, how to do this?
Sir, we cannot ascertain after death. We cannot ascertain. Only answer will be autopsy, sir. Through autopsy, we can know, because otherwise, sir, we do not have. If a patient has underlying heart disease, like a patient of post-MI patient with LV dysfunction, then we can be then also we cannot be certain that. But with a high probability, we can say that patient had a acute event like arrhythmia, like ventricular tachycardia or ventricular fibrillation. But after that death, by any means we cannot say whether this patient has died because of a MI or because of arrhythmic event.
But this corporation medical officers, they keep on asking, please mention what is the card, whether he has a comorbidity condition or whether he has died due to this. All these things they will keep on asking because of the statistics.
Yes, but sir, no one can be confident without autopsy, sir. It will be very difficult to say that whether this patient had any electrical abnormality, whether this patient has any genetic disorder. So this is very difficult to say, sir. After death, we can only give a probability. Okay, this might be because of MI or this might be because of any BTVF, but we cannot be certain.
Okay, thank you very much. It is a wonderful presentation. Beautifully, you have made a topic, and wonderfully you have advised all the chapter. Thank you very much.
Thank you, Dr. Tyagaraja, sir. Now there is one question, last question from our chat box. This is Dr. Sanjay Rotitor, our Vice President of IUH from Pune. He writes, in hypertrophic cardiomyopathy, if antihypertensive dose of drugs required is high, are such patients indicated for ICD with benefit?
If in hypertension, sir, per se hypertension is not an indicator for ICD, sir. If a high dose of a patient is requiring high dose of hypertensive drug, this is not at all an indication. We have in patients with hypertrophic cardiomyopathy, if we want to stratify them, then the risk factors remain same, like if they have survived any sudden cardiac death, if they have any family member of sudden cardiac death, if there is on Holter monitoring, if we find that there is evidence of NSVT, VT, or if we have blood pressure, the blood pressure doesn't rise while the patient performs TMT, and on echo, if there is evidence of LV thickness is more than 30 mm, these are the risk factors, only risk factors, and few genotypes. These are the risk factors which indicate whether the patient will require ICD or not. The dosage or the number of antihypertensive drugs, this doesn't indicate such patients.
Okay, so hypertension as such is not the indication.
Not a risk factor. It's not a risk factor.
So now there is Dr. Kishorji Parikh from Vadodara. He is our Joint Secretary from IUH. Now, Dr. Kishorji Parikh, he has raised his hand. You can unmute, boss. Doctor,
hello. Yeah. It was Prashant sir. It was very excellent presentation in a very simple manner. So, can you please highlight about collateral development, sir? Because as age advances, it is very important.
The collaterals, these are in coronary circulation. Collaterals are present since birth, but
yeah,
they whenever an artery occludes, we have development of collateral. If the occlusion is slow, if occlusion develops very slowly over a period of years, then we have good development of good collaterals. We take care of the other segment of the artery. But if suddenly if a patient has sustains an MI, then these collaterals usually they will not develop within hours. So the importance of collaterals remains that if a patient has a well collateralized heart and if they sustain MI, then they have less chance of developing LV dysfunction, less chance of developing sudden cardiac death. While in scenarios when patient has acute coronary syndrome without development of collateral, these patients do have chance of developing electrical abnormalities, BTVF. They have chance of having lower ejection fraction. So this is the importance of collateral. Collaterals are present in everyone's heart since birth. But to have to develop collateral, to have a good collateral circulation, these develop only when stenosis develops in a very slow pace.
Okay. How can we assess, sir? Is there any test for it?
Sir, usually if you do not have any coronary artery disease, there is no need to assess the collateral. We cannot assess the collateral circulation. This can be assessed only when you have any obstruction in a coronary artery. Then by this coronary angiogram, by PET perfusion, we have PET scan which can also assess the amount of collateral circulation. Otherwise, we do not have other tests which can assess. See, now we have CT scan also, but this will only tell about bigger collaterals. The minor collaterals, they cannot tell about the extent of minor collaterals.
Okay, thank you, sir. Yeah.
So now we have come to the end of this particular session now. We are also joined by Dr. Shyam Pingle, our past president and member of board, International Commission on Occupational Health Board. So, sir, would you like to have some comment or some queries? Else, yeah. So you're not audible. Other panelists, if they have any query, they can unmute themselves. I think he's actually Dr.
Actually is traveling in Shatabdi.
He's traveling. Yeah, there is. Yeah, he's traveling. Yeah, that is the reason why some connectivity issues are there.
Yes.
So anyway, but thank you very much for joining this 75 Diamond celebration of our ENOCH DigiConnect webinar series. And now with this, I thank you very much, Dr. Prashant Panda, for this great deliberation about the sudden cardiac arrest. And a lot of issues, they have been clarified. And as Dr. Rajiv sir has told, that quality and performance indicators, we have to focus more on that. And we have to educate the layman with a special awareness on sudden cardiac death. And we all industrial physicians, we should keep in mind the risk factors and the risk stratifications for sudden cardiac death. So with this, we will be able to prevent a lot of precious deaths, which may be outside the hospital scenarios, maybe in our offices, in our factory premises, or in some crowded spaces. In that case, the first thing, as you told, that we should immediately go for CPR. If defibrillator is available, we should give him defibrillation, and then definitive treatment we should start as soon as possible, because time is the precious thing, and within 10 minutes we have to do the whole efforts. Otherwise, because of the low cerebral perfusion, we may even save the patient, but he can go in comorbid condition, he can go in coma, he can go in brain death, and that will be a further pathetic position for that particular patient and for the whole family and the organization. So thank you, Dr. Panda, for giving this deliberation. If you have time, you can join us for this 40th Ruby episode of our ENOCH this COVID Epid update, which is deliberated by Dr. Rajiv Kumar Jain sir, our president, vice president of AUSD, and he is also senior consultant in Indian Railways, and he is public health physician, senior consultant, and with 40 years of experience in health and hospital administration, and he is fellow award from Public Health Association and from the Environment and Occupational Delhi, and he has published more than 145 scientific papers and fellowship and scholarship from WHO, NIH, National Institute of Health, USA, Canadian Society for International Health, an international clinical epidemiological network, and International Society for Priority in Healthcare. So Dr. Rajiv Kumar Jain sir, he has been a great resource person during this whole COVID pandemic, and he has been guiding us how to take care of our workforce, of ourselves, our families, so that we can take care of others. Thank you. And now Dr. Rajiv Kumar Jain sir, the floor is yours.
Thank you, Dr. Sandeep. I must congratulate all the speakers for the 75 episodes of ENOCH DigiConnect webinar series, and from 1st to 75th, so 75th episode, Dr. Prashant. I congratulate him also to be the Diamond Jubilee speaker. And now we are here in the evening of 20th of October 2021. And who could imagine that we would be meeting so regularly on a virtual format and enjoying the academic feast? The COVID-19 epidemiological updates originally started with apprising the principles of epidemiology to occupational health physicians and industrial physicians, so that they understand that epidemiology is a living science. The clinical epidemiology is also a living science. So we marry the two subjects of clinical epidemiology and conventional epidemiology in this live historical archival effort of AUHD, where we deliberate on the dynamic epidemiological situation globally, regionally, in the country and in the states and the districts. And we analyze where are we have reached, and how we would be, how likely we are going to travel this journey in the days, months, and years to come, and how we can understand the principles to practice in our day-to-day practice. Today's episode is unique in many ways. Besides being the 40th episodes, we are celebrating the 100 crore vaccination achievement by India. Besides celebrating and understanding India's billion dose landmark, we shall also take a look at new guidelines for international passengers, flu and COVID-19 relationship, and in relation to Dhanteras, we shall have a little session on iron deficiency anemia in women. And iron and gold, both are elements. We will take a look at that. So let's start with the 100 crore vaccination anthem. Here we go to listen and participate in the 100 crore vaccination anthem.
हम देशवासियों ने, हमारे वैज्ञानिकों ने, हमारे उद्यमियों की ताकत का ही ये परिणाम है कि भारत को वैक्सीन के लिए किसी और देश पर हमें निर्भर नहीं होना पड़ा।
ना हम रुके कहीं, ना हम डिगे कहीं, ना हम रुके कहीं, ना हम डिगे कहीं, शत्रु हो कोई भी हम झुके नहीं। दुश्मन के शस्त्र जो हो हजार, शतकोटि कवच से हम तैयार। मेरे भारत का ये विश्वास है, सबका साथ सबका प्रयास है। भारत का टीकाकरण लिख रहा एक नया इतिहास है। शतकोटि गर्व एहसास है, ये एक नया इतिहास है, इतिहास है। धन धन धनान धन, धन धन धनान धन, धन धन धनान धन, धन धन धनान धन। जो दे रहे 100 करोड़ को जीवन, उन हाथों को शत शत नमन। इस युद्ध में जो लड़ रहा वो हर सिपाही खास है। शतकोटि गर्व एहसास है, ये एक नया साथी पर मेरे देश को विश्वास है, सबका साथ सबका प्रयास है। भारत का टीकाकरण लिख रहा एक नया इतिहास है, शतकोटि गर्व एहसास है, ये एक नया इतिहास है, इतिहास है। शतकोटि गर्व एहसास है, ये एक नया इतिहास है, इतिहास है। धन
100 करोड़ वैक्सीनेशन के साथ आज भारत लिख रहा एक नया इतिहास है। ये हमारा शतकोटि गर्व का एहसास है।
हम देशवासियों
So friends, after achieving the landmark of 100 crore vaccination, let's try to understand the epidemiological aspects of this achievement. Let's understand India's billion dose landmark. India administered its billionth dose of COVID-19 vaccines early on Thursday morning. The only country other than China with 2.2 billion doses administered to cross the milestone. India's adult population, the only one eligible for vaccines right now, is estimated at 940.2 million. And this milestone in absolute numbers is a milestone in coverage too. As of 5 p.m., around 76% of adults in the country had received at least one dose of the 2-dose vaccine, and around 31% have been fully vaccinated. Seen in the context of the last national seroprevalence survey, these tests for antibodies, the seroprevalence surveys, that showed that almost 2/3 of the population had been exposed to COVID-19, and the current low daily case numbers, the vaccination statistics mean that India will likely not see a third wave of infections, according to experts. But India's high population of 1.3 billion also mean that the country's vaccine drive still has some distance to cover. Let's see it in 4 slides. The first, let's understand that today, half the districts have covered 75% of their population with at least one dose. In the map of India that you see, the blue color of the districts shows more than 95%, green is 90 to 95%, yellow is 75 to 90%, red is 50 to 75%, and brown is 24.6% to 50%, one dose of vaccine. The 1 billion dose count has come along with coverage of 75% of adults with at least one dose. At the district level, a little over half the district, that is 345 of 628 districts of 2011 census, with all of Delhi's and Mumbai's district taken together, have reached this level of coverage. The top 5 districts in terms of coverage of first dose are Diu, Kolkata in West Bengal, Gurgaon in Haryana, Solan in Himachal Pradesh, and Dadra and Nagar Haveli Union Territory. The first dose coverage in these districts is the complete adult population as estimated through the number of electors. Another 261 districts have given at least one dose to 50 to 75% of their population. Only 22 districts have vaccinated less than 50% of their population. 16 of these 22 districts are in the northeastern states, 9 in Nagaland alone, and other 6 are in Maharashtra, Tamil Nadu, Uttar Pradesh, and Chhattisgarh. So let's understand and focus on these districts which are brown in the map. Now let's take the second issue. Himachal has achieved close to twice the vaccine coverage of its adult population as Jharkhand. If you see on the left is Himachal and on the right is Jharkhand. There are significant variations with India. Himachal Pradesh has administered at least one dose to all adults, while Jharkhand has covered only 58.6% of its adults. In the share of fully vaccinated adults, Himachal Pradesh, 57% adults fully vaccinated, is 3 times ahead of Uttar Pradesh, which has fully vaccinated the least, that is 19%. But again, the population of the two states are in entirely different ranges. Himachal Pradesh has an adult population of 5.5 million, while Uttar Pradesh has its adult population of 147.4 million. See the diversity and the truth of India. It's a continent. It's not only states. Each state is almost equal or bigger than many of the countries in Europe. Let's see the third dimension. Inter-district disparity is still high, but it is lower than earlier. If you see the graph on the right side, the ratio of total doses per 100 adults in top 25 districts with other quartiles, you will know what I'm trying to tell you. Bottom 25% districts are in dark blue. Light blue is 25 to 50%, and red are in 50 to 75%. Now you see the trend. All have gone down. That means district disparity is reducing. National and state level projections for 2021 population are available from the National Commission on Population. There's no such projection at the district level. Therefore, one has to use the number of electors at the time of 2019 Lok Sabha elections as a proxy for adult population at the district level. Diu has administered at least one dose of vaccine to 222% of its adult population as estimated by the number of electors, and both doses to 145%. This could be because of people from other districts getting vaccinated in Diu, apart from a change in population or low registration of adults as electors. In contrast, Senapati in Manipur, the worst performing district, has administered at least one dose to only 24.6% of its population, and both doses to 11.9%. Such individual comparisons can, however, be misleading because these districts are outliers. A better way to check inter-district disparity is by classifying districts into quartiles, that is bottom 25% to top 25%, that is 4 quartiles, for each day of vaccination. This shows that the top 25% districts have given twice the number of doses per 100 adults as the bottom 25% districts. This disparity is, however, much lower than earlier. At the end of January, the top 25% districts had given 5 times the number of doses per 100 adults as the bottom 25% districts. Even on May 1st, when vaccination was opened up for all adults, this ratio was 3.8. The gap is clearly narrowing. So that's a wonderful thing to happen for India. If we focus on reducing inequity, we are doing fair allocation of vaccination. Let's look at the last and the fourth dimension. India's 1.3 billion population poses a challenge. Population covered with at least one dose in big countries is the graph on the right side in orange. And India is marked in orange, 52.2%. Global vaccination data is available up to different dates from different countries. Taking the latest data for each country, India was second in the world in administering COVID-19 vaccines in absolute numbers. In terms of proportion of total population that has received at least one dose of the vaccine, India with 52% coverage overall population ranks 101. On top of the list are two British overseas territories of Gibraltar and Pitcairn Islands with full coverage. But the population of the former is only about 34,000 and the latter is less than 50,000. United Arab Emirates with 96% coverage comes next, but it also has a population of only 10 million. Among bigger countries or those with population of 100 million or more, India is ranked 5th among 12 countries for which this data is available. Japan has covered the highest now share of its population with at least one dose among these, that is 76%. So you see on the right in the picture bar diagram, Japan is extreme right, and then Brazil, then United States, then Mexico, and number 5 is India. Then after India is Indonesia, then Russia, Pakistan, Bangladesh, Egypt, Ethiopia, and Nigeria. If you look at this, in spite of the challenged population, India has achieved tremendously well. If you look at the challenges, because during this vaccination process, India faced the Delta variant, the second wave of the pandemic, which was so lethal. Even during the second wave, vaccination went on admirably well, and September month of this year was amazing. India achieved tremendously better coverage of vaccination with COVID-19 than any month in 2021. So September 2021 is a big landmark. And again, 21 of October 2021 is definitely a historic day to remember in the history of vaccination in the world, because India achieved 100 crore vaccination doses on that day, very early in the morning. So let's go on to now understand, which we do every week, the global, regional, local situation of COVID-19. With just 2.7 million new cases and over 46,000 new deaths reported during the week of 11 to 17 October 2021, the global number of new cases and deaths remained similar to that of the previous week, which is shown in the next figure. Apart from the European region, which reported a 7% increase in the number of new weekly cases when as compared to the previous week, all the other regions reported declines in new weekly cases. I will show you in the next table this data. The largest decrease in new weekly cases was reported from the African region, that is 18%, followed by the Western Pacific region, 16%. The cumulative number of confirmed cases reported globally is now over 240 million, and the cumulative number of deaths is just under 4.9 million. The Africa region also reported the largest decline in weekly deaths, that is 25%, followed by the Southeast Asia and the Eastern Mediterranean regions with 19% and 8% declines, respectively. All of the regions reported new deaths in numbers similar to those of the previous week. Let's look at the table in the next slide. Here you find a column on the left is new cases in the last 7 days, and in brackets are the percentages. If you look at this figure, highest contribution is by Europe, that is 49%, 13,58,000 new cases in the last 7 days out of 27,63,000 in entire world. So Europe again has become the epicenter of the world in COVID-19 spread, with in the last week 7% increase in cases and 4% increase in deaths. We will see further which countries are contributing to this increase in Europe. Next slide, please. This is the graph of each region of the world. On the left top in yellow, you find Americas, where the fourth wave is on the decline slope. In Europe, what you see, you see the fourth wave suddenly jumping up. Sudden jump. Fourth wave going up from the same wave peak. Southeast Asia, you are seeing the third wave on the decline. Eastern Mediterranean region, you also seeing the fourth wave, the highest wave on the decline. On Western Pacific bottom left graph, you are seeing the fourth wave going down on the decline side. In Africa, the third wave on the decline slope. Next slide, please. This is the true figure of today, which will be taken about an hour back from the World Health Organization coronavirus disease dashboard, where we see in the world in the last 7 days, 28,90,000 cases, out of which 16 lakh cases. 16 lakh out of 28 lakh were in Europe, and 7,62,000 were in Americas, while only 1,96,000 were in Southeast Asia, and Eastern Mediterranean 1,27,000, Western Pacific 1,81,000, and Africa only 24,000. If we look at the deaths newly reported in the last 7 days, again we find Europe contributing 20,470 deaths out of 47,000 deaths globally, which is the most significant region for deaths. And in last 24 hours, Europe has contributed 3,196 deaths out of 7,153 deaths. So again, Europe is definitely the epicenter for cases and deaths today and the last 7 days in the world. Let's see which are the countries. Next slide, please. This is the ranking of the countries in terms of top to bottom, where top is the highest number of cases in the last 7 days, which is United States of America with 5,32,000 cases out of 28,90,000 cases globally. United Kingdom got 3,23,000 cases, and Russian Federation. Imagine, Russian Federation is now showing 2,43,000 cases in 1 week, and it is the third highest country in terms of reporting cases in the world today. In the last 24 hours only, Russia Federation has shown that 37,141 new cases, while United Kingdom shown 51,000 and United States of America 74,000. So these three countries, the most powerful countries in the world, are still reeling very much due to COVID-19 pandemic. And specifically, Russian Federation is bearing a brunt, more than 1,000 deaths every day. Turkey is number 4, 2 lakh cases. Ukraine of Eastern Europe is 1,14,000. India is at number 6 position with 1,05,000. Romania of Eastern Europe is 1,04,000. Germany 83,000. Brazil 82,000. And Iran, Islamic Republic of Iran, 79,000. So what you see, predominantly the pandemic has shifted from the Americas to Europe now, and it is affecting more of Eastern European countries, mainly Russian Federation, Ukraine, and Romania. And we will see more infection rising in these countries for some time. As you would know, Russia has announced total workplace cessation from 30th of October to 7th of November. And then they will decide further what to do after 7th of November, whether total lockdown or not. Russia is going to decide after this workplace cessation from October 30 to 7th of November. Next slide, please. This is the ranking of the countries in terms of deaths during the last 7 days. Out of 47,798 deaths, 11,000 were from the United States of America. Russian Federation has 7,140 deaths with 1,064 deaths in the last 24 hours. Ukraine is number 3 with 2,866 deaths. Romania is number 4 with 2,700 deaths. Brazil and Mexico are number 5 and 6 at 2,600 and 2,100. Turkey, Iran are numbers 8 and 9 at 1,400, 1,265. India is number 10 and Philippines is number 11 in terms of deaths. So this is the condition today. Again, this brings home the point, Eastern Europe is reeling under the effect or the burden of pandemic of COVID-19 is being borne by Eastern Europe. Ukraine, Romania, and Russian Federation together are affected, and it's going to rise in the days to come. Next slide, please. This is the global scenario in terms of COVID-19 cases per 1 lakh population reported by countries, and darker the color, that is dark brown, is the highest concentration per lakh population, and you see those that dark color is entire Eastern Europe, and you see even in USA, even in UK, you find dark color is there. Romania, Ukraine, all are dark. Next slide. This is the COVID-19 deaths per 1 lakh population. Dark blue, darkest blue is the highest deaths per 1 lakh population, and you're finding Eastern Europe again affected. Besides United States of America, few countries in northern South America are affected with this. Next slide. Let's look at the regional situation, that is India and its neighbors. Declining trends continued in Southeast Asia region with just under 2,15,000 new cases and over 2,900 new deaths reported, decrease of 13% and 19% respectively as compared to the previous week. All countries in the region reported a decline in new cases and deaths this week, apart from Thailand, that reported a similar number of cases as compared with the previous week. The highest number of new cases were reported from India, that is 1,14,000 with 18% decrease. Thailand, 72,000 cases with similar number as those reported last week. And Myanmar, 9,202 cases with 10% decrease. The highest number of new deaths were reported from India, 15,335 new deaths with 13% decrease. Thailand, 582 new deaths with 14% decrease. And Indonesia, 301 new deaths with 37% decrease. And you see the trend on the graph at the bottom, which is showing the third wave is declining. Next slide. Now we come to India and its states. The overall summary of COVID-19 in India is 16,291 new cases in last 24 hours, 666 deaths, and 13.5 lakh tests. 7-day average test positivity rate, 1.3%, 1.7 lakh active cases. They are shrinking by 2.1%. Total 3.42 crore cases and 4,53,742 deaths have been reported. Total vaccinations are 101.2 crore vaccination with 63 lakh vaccinations given yesterday. Let's go to the states now. This is very important for us to review the situation. If you look at confirmed cases on the left, Kerala is at number 1 with 9,361 cases out of 16,000. Maharashtra second, Tamil Nadu, West Bengal, and Mizoram are at number 2nd, 3rd, and 4th and 5th position. In terms of deaths, out of 666 deaths, 583 deaths were only from Kerala, Maharashtra 40, Tamil Nadu 19, West Bengal 12, and Karnataka 11. These are the top 5 states with deaths. Tests per million per day, Mizoram 6,420, Andaman Nicobar 3,670. But look at the bottom. Rajasthan, Nagaland, West Bengal, Manipur, Arunachal are not testing enough. 7-day average test positivity rate is very high in Mizoram, which is 23.7, while Indian average is 1.3%. Meghalaya, it is 16.6%. Kerala, it is 10.4%. Manipur is 4.1%. So it is still very high infection rate in Mizoram, Meghalaya, Kerala, and Manipur. 7-day average daily growth in percentage, while Indian average is 0.04%, Mizoram is 0.66%, Kerala is 0.17%, Meghalaya, Himachal, Manipur, and Nagaland are also showing higher than Indian average. If you look at the vaccinated person with at least one dose in percentage, Indian average is 52.45%, Nagaland is only 32.1%, Meghalaya is only 33%, Jharkhand is only 37%, Manipur 39%, Bihar 39%, and Uttar Pradesh is 41%. So these are the states which are in their efforts to increase the vaccination with the first dose of their population above 18 years of age. Next slide. This is another important slide where proportion of current global of variants of concern or variants of interest sequences reported among total sequences submitted over time by the WHO region as on 15th of October 2021. Alpha is in orange, beta is in blue, gamma is in brown, delta is in purple, and a mu and lambda are in dark green and light green color. So what do you see? Africa, Americas, Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific. The dominance is by Delta. The Delta variant is now rampaging its path of growth across the regions of the World Health Organization. No region is unaffected by Delta variant and most lethal variant amongst the COVID-19 pandemic variants of concern. Next slide. This is the graph where each graph shows a map of the world. First map is of alpha variant, how it is spreading, and you find that the dark blue is the proportion of vaccine variants of concern among total sequences. Countries which are taken up, darker is the highest, and you find alpha variant is being reported from across the world. Beta variant concentration reporting is from Americas. Next slide, please. Gamma is from mainly South America and North America and part of Northern Europe. But look at Delta. Delta is so dark across Southeast Asia, Australia, northern part of South America, entire Northern America, and almost entire Europe. So the most lethal is most rampant or spread out infection, dominant strain in the world. Next slide. This is important to understand that Government of India has brought out new guidelines for international passengers. All international passengers will have to produce a negative RT-PCR test report for COVID-19 at the time of their arrival in India, according to the Health Ministry's latest guidelines for international travel issued on Wednesday. A look at the new rules that will be valid starting October 25, that is from Monday. At the airport, thermal screening will be carried out on all passengers by health officials present at the airport. Passengers found symptomatic during screening shall be immediately isolated and taken to medical facility according to health protocol. If tested positive, their contacts shall be identified and managed under laid down protocol. At sea or land ports, international travelers arriving through seaports or land ports will also have to undergo the same protocol, except the facility for online registration is not available for them as of now. They must submit their self-declaration form to officials at the seaports and land ports on arrival. On the right is an algorithm where new standard operating protocol for international passengers have been shown. Before travel, passengers fill up a self-declaration form on Air Suvidha portal and uploads a negative RT-PCR report. Airlines must ensure that all passengers have a negative RT-PCR test report before allowing them on the flight. When passenger arrives in India, there are two possibilities passengers who are coming from countries labeled at risk by India. These are nations from where travelers need to follow additional measures on arrival, including post-arrival testing. They include South Africa, Brazil, Bangladesh, Botswana, China, Mauritius, New Zealand, Zimbabwe, and many countries in Europe, including the United Kingdom. The nations that have a pact with India on mutual recognition of vaccine certificates and are fully vaccinated, they will have self-health monitoring for 14 days after arrival in India. Persons who are not or partially vaccinated with nations where India has mutual vaccine agreement, they will have to have post-arrival COVID-19 test, home quarantine for 7 days, and retest on the 8th day, and if negative, self-health monitoring for the next 7 days. This shall also be the policy for all the remaining countries, whether they are fully vaccinated or not, or partially vaccinated. But for travelers arriving from nations that are not listed as countries at risk, travelers who are flying in from all countries, excluding those nations that have been marked as at risk by the Indian government, will be allowed to leave the airport on arrival here. But they will have to give a self-health monitoring for 14 days after arrival in India. Now, all these passengers, if any traveler develops symptoms during 14-day post-arrival period or test positive for COVID-19 after arrival in India, then they must immediately self-isolate and report to the nearest health facility or contact the national, that is 1075, or the state helpline number. Now, who is at risk? Countries from where travelers need to follow additional measures on arrival in India, including post-arrival testing. India will recognize vaccines that are either A, approved by the government of India, or B, WHO recognized vaccine. So this is the new guidelines for international passengers, which will be followed from 25th of October 2021. That is from next Monday. Next slide. Let's the overall situation of COVID-19, vaccination and the pace of vaccination, and cases and deaths. India crossed the key landmark of administering 1 billion COVID-19 vaccine doses on Thursday, having given half its population at least one shot. The scale has helped it address some of the distribution inequities over time, but not in full measure. That is what the data shows. Half of all Indians live in 5 states, that is Uttar Pradesh, Maharashtra, Bihar, West Bengal, and Madhya Pradesh. But just 41.5% of all doses given in India have gone to these states so far. In terms of doses given per 1,000 population, Uttar Pradesh, that is 508, and Bihar with 505, they lag the national average of 729. The gender inequity that existed in early stages has been addressed, with 99 women getting a jab for every 100 men in the last 1 month, from only 79 per 100 in June. However, some states with high vaccination coverage are underperforming. Delhi, for instance, has given doses to 723 females per 1,000 males, a gross mismatch against its sex ratio of 876 per 1,000. With 45 plus age group receiving 1,270 doses per 1,000 population, nearly 73% are yet to get fully vaccinated. The younger lot, that is 18 to 44 age group, accounts for 74% of India's population and have received 55.5% of the total doses. Since August, 60% of all doses have gone to this age group. As vaccination expands, these disparities are likely to taper. However, the pace of vaccination has slowed this month to 5.3 million doses a day, compared to 7.9 million and 6.1 million in the previous 2 months. As more vaccines enter the market, the rollout will get a push. Next slide, please. The first 8 months. Let's look at the first 8 months. The outbreak in India continues to subside. India reported 106,770 new cases in the last 7 days, down 16.2%. Kerala at 59,092 new infections reported more cases than all of the other states and union territories combined. Ernakulam, Thiruvananthapuram, and Thrissur districts accounted for 40.6% of all cases reported in Kerala. For the first time since February end, every single district in India reported fewer than 10,000 cases in the 7-day period. Only for 100 districts did the number of new cases grow this week. But in most cases, the rise has been less than 20 cases. The exceptions are Serchhip of Mizoram and Una of Himachal Pradesh, which reported 660 and 112 new cases, up from 426 and 85 respectively. In Nagaland's Tuensang and Jammu and Kashmir's Doda district, the count has been rising steadily since the past 3 weeks. Next slide, please. There has been a big drop in the pace of vaccination. In the last 7 days, India's vaccination coverage grew just 2.2%, the third slowest among the 10 most populous countries for which data is available. If you look at the pink figure, India is at the bottom fourth. Indonesia saw the fastest growth for the second straight week, followed by the Philippines and Mexico. Indonesia, which recently saw a devastating COVID-19 outbreak, aims to administer 300 million doses by the end of this year, even as famed tourist destination Bali is set to reopen to vaccinated tourists. The Philippines received 844,800 AstraZeneca vaccine doses from Germany through the COVAX facility earlier this week. It also began to vaccinate its teenage population with comorbidities. Russia registered its highest daily COVID-19 death toll this week. Since the pandemic began early this last year, it has so far only administered 670 doses per 1,000 people. Only about 42 million of Russia's 146 million citizens have been fully vaccinated. Next slide, please. Let's look at the tolls in terms of deaths. India reported 1,377 new COVID-related deaths this week, 13.2% fewer than the preceding week. The decline has been constant for the past 2 weeks. All states and union territories except Haryana and Punjab reported fewer deaths this week, with 14 reporting none. Haryana, which had reported no deaths last week, added 174 deaths this week, most of which were retrospective as part of a reconciliation exercise. Punjab reported 18 deaths. Kerala continued to report the most deaths, that is 513, but down 33%. Of the 4 districts in India that reported over 50 deaths, 3 are in Kerala. Thiruvananthapuram reported 197 deaths, the only district with over 60 deaths in the past 7 days. India must keep working to address inequities in the vaccination drive and to pace it up consistently to ensure more lives are not lost due to the pandemic. Having reviewed the situation of epidemiological situation of COVID-19 regionally, nationally, and subnationally, and globally, we should now take up another issue of importance. That is flu and COVID-19. Let's look at it from a question answer format, and who shall be better equipped to tell us than Dr. Sylvie Bryant, who is the Director of WHO Infectious Hazard Management.
As flu season is starting in many parts of the world, how would you know if you have flu or COVID-19? Hello and welcome to Science in 5. I'm Vismita Gupta-Smith. We are talking to Dr. Sylvie Bryant about flu and COVID-19 today. Welcome, Sylvie. Sylvie, let's start with how would people know if they have caught the flu or COVID-19?
So the flu is very common, especially in this season, and usually the symptoms are fever, headache, muscle ache, but also upper respiratory symptoms such as sneezing and coughing. For COVID-19, it's the same symptom basically, but in addition we have specific symptoms such as anosmia, which is a lack of smell, and ageusia, which is a lack of taste. And many people, especially young people, have experienced this additional and specific symptom for COVID-19. But sometimes people have very few symptoms, whether it's for flu or for COVID-19. It really depends on your level of immunity. what is important to know really for those two diseases is that the prevention measure works for both of them. And especially washing hands, it's very important. Then ventilation of rooms when you are in crowded rooms with a lot of people in particular, so open the window. Also wearing mask if you cannot open the window, and maintain physical distancing. And both diseases are really preventable if we apply those measures.
So Sylvie, talk to us about the groups that are most at risk from the flu, and also talk to us about the safety of taking the flu vaccine for those people who do have access to the flu vaccine and the COVID-19 vaccine. Is it safe to take it?
So the group most at risk for influenza are elderly, people with underlying conditions such as chronic respiratory disease, cancer, cardiovascular disease, and these are a similar group as for COVID-19. But for flu, in addition, pregnant women and very young children, infants, are also more at risk for severe disease. So is it safe to administer flu vaccine and COVID-19 at the same time? Yes. We have now few studies that show that it is safe to have both vaccines at the same time. But of course, people need to check with their physician about their indication to take both vaccines.
Sylvie, talk to us about how the composition of the influenza vaccine is decided, and also speak to us a little more about the safety and efficacy of the flu vaccine.
There are many different influenza viruses out there, and actually they change very often. And so what is very important is to know what are the predominant viruses in a given setting, so that we can take the antigen of this virus to compose the vaccine. So that's why we have around the world 136 laboratories constantly monitoring the circulating viruses, and twice a year we have expert meeting to define what are the predominant viruses in certain places of the world. So we have 2 vaccine composition meetings per year, one for the Northern Hemisphere and one for the Southern Hemisphere. So the flu vaccine has existed for many decades, and it's a very safe vaccine. But it's very important to have those expert meetings to define the composition of the vaccine, to make sure that we put in the vaccine the component that will really better protect people against the circulating viruses at a given time. And this vaccine is very recommended to at-risk people so that they can be protected against severe flu and death when the season starts.
Thank you, Sylvie. That was Science in 5 today. Until next.
Well, this is a summary of flu and COVID-19, and I hope the audience would have found it more relevant because the flu season is coming. I would like to go back to this slide presentation, which is next slide, please. Next slide.
I think there is some technical problem with connectivity problem with Dr. Rajiv. Shivang, can you contact with him?
Yes, sir. Yes, sir.
Yes, sorry for the interruption, the connectivity issue. As key climate summit, all eyes on attendance at the Glasgow UN Climate Change Conference in UK, where several prominent figures are endowed to attend the UN COP26 Climate Summit in what would make or break efforts to agree on steeper emission cuts in the fight against global warming. Who are attending? Attending will be our own Prime Minister, Narendra Modi, US President Joe Biden, along with climate envoy John Kerry, Queen Elizabeth, Prince Charles, and Prince William, along with Camilla, the Duchess of Cornwall, and Kate, Duchess of Cambridge. Then European Commission President Ursula von der Leyen, European Union Climate Policy Chief Franz Timmermans, and the bloc's energy and financial services policy heads, Israeli Prime Minister Naftali Bennett, Australian Prime Minister Scott Morrison, Turkish Prime Minister President Tayyip Erdogan, French President Emmanuel Macron, Canadian Prime Minister Justin Trudeau, Italian Prime Minister Mario Draghi, Colombian President Ivan Duque, Swedish Prime Minister Stefan Löfven, Swiss President Guy Parmelin, South Korean President Moon Jae-in, Democratic Republic of Congo's President Felix Tshisekedi, Ghana's President Nana Akufo-Addo, and Argentinian President Alberto Fernandez. The three big stakes and a divided approach are fossil fuel impact, eating less meat, and money for poor countries. A significant number of Switzerland's comments are directed at amending parts of the report that argue developing countries will need support, particularly financial support, from rich countries in order to meet emission reduction targets, and Australia makes a similar case to Switzerland. Brazil and Argentina, two of the biggest producers of beef products and animal feed, argue against evidence in the draft report that reducing meat consumption is necessary to cut the emissions. The report states plant-based diets can reduce greenhouse gas emissions by 50%. Brazil and Argentina are opposing this. The leak reveals Saudi Arabia, Japan, and Australia are among countries asking the United Nations to play down the need to move rapidly away from fossil fuels. India is one of several countries lobbying the United Nations against completely moving away from fossil fuels like coal. So there will be debate, there will be disagreements, but there will be decisions as well, which will allow the world to progress further. So we should wait for this COP26 Congress and the second week, that is 9th of November 2021 in Glasgow, Scotland, United Kingdom. Now with this summary, I would like to take you back to another event that is occurring just before Diwali, that is Dhanteras, and gold will be in demand. But another metal which should be in demand should be iron. Let's look at one interesting video highlighting the importance of iron for prevention of iron deficiency anemia amongst women.
सोना सोना तू करती पर सोना क्या जाने तेरा मोल रगों में तेरी लोहा हो तो तू हो जाए अनमोल तेरी मिट्टी में है लोहा तेरी लहू में है लोहा ओ बुड्ढी लोहा चख ले ओ हीरे ये लोहा चख ले लोहा चख ले सोना बन जा अपना ही तो कहना बन जा लोहा चख ले सोना बन जा अपना ही तो कहना बन जा ओ बुड्ढी लोहा चख ले ओ हीरे ये लोहा चख ले ओ जुगड़े लोहा चख ले
So thank you so much for your patient listening. COVID-19, flu, and iron, besides the climate change. So that was a message for this Ruby Jubilee edition of COVID-19 Epid Updates. I'm really grateful for your attention because attention is the rarest and purest form of generosity. I'm grateful for your generosity. Thank you so much.
Thank you, Dr. Rajiv sir, for giving us an overview of the current situation of the COVID pandemic. And yes, we are celebrating the 100 crore doses of COVID vaccine in India, which have been administered. But seeing our population, as you rightly told, only 76% of the population has received the first dose, and only 26% has received both the doses, and still our children are unvaccinated. So, seeing the crowded population in the crowded areas and the coming festive season and the coming change of the season, still we need to be very careful. And as the government has also launched this mission 100 days, in which they have requested everyone not to put their guards down for next 100 days, because these 100 days are very crucial, in which we'll be covering the maximum population with the COVID vaccine. And this festive season will be over, and there will be change in the weather also. So we need to be careful about the COVID, and we need to be careful about the flu. As told by the WHO scientists, we can go for flu vaccination also, as per the latest strains which have been developed. And COVID vaccination along with flu vaccination is ideal to save ourselves and from these flu-like illnesses. And since it is difficult to identify clinically between the COVID and the flu, so we should always be careful whenever someone gets flu-like symptoms. We should get ourselves tested for COVID, and we should isolate ourselves, do sanitization, do hand washing. And in addition to that, iron, as the importance of iron is definitely, because iron is one of the important constituent of our body. And many of our females in India, they are, and children, because of the malnourishment, they are anemic, and we need to be very concerned about all of them. And if the panelists have some question, or the participant, they have some question, they can raise their hands and they can ask. Else, I have one question, Dr. Rajiv sir. The foreign travel guidelines have been issued, and now foreign travel will also be starting. Now, what is the status of this Covaxin approval by WHO, sir? Because that is very important.
Yes, very, very relevant question. On 26th of October, the committee of experts is meeting next week, and they will take a call on the comments and documentation given by the company, that is Bharat Biotech, in reply to their previous clarifications. And hopefully we should move substantial forward on 26th of October. That is the current position. Let's wait for the meeting to happen and wait for the results from that meeting.
And there's one from Q&A box. There's one question: is there any difference with respect to COVID now, please?
Meaning, I couldn't get the question.
Means he wants to know whether
for the previous speaker.
No, with respect to COVID, now the situation has improved, or now what is the difference with respect to COVID? Like earlier, the situation was not good. Now, has it improved, or it is still?
Situation is very dynamic. As I showed you, the situation is very bad at the moment, and it's going to get worse in Eastern Europe, mainly Russia, Ukraine, and Romania, where the deaths are occurring very high, and also the cases, new fresh cases. That means transmission is happening, active transmission is happening in these three countries. And that's why Russian Federation has taken a decision to close all workplaces for 7 days, effective 30th of October up till 7th of November. And they may take more harsh measures based on the data that they collect on the ground. So things will keep on moving in one one region to another region. So this is very difficult to predict. But no doubt in India, the fear of third wave being very severe than the second wave has receded. People have realized that this may not happen because of simple reason that vaccination has been substantive, as well as zero prevalence rates due to Delta variant and COVID-19 variant is very high. And in any case, the zero prevalence surveys are being conducted. We shall see the results of zero prevalence surveys sometime during next week to 10 days, both for Delhi and for the country, which has shown in the past there has been substantial population which has been exposed to COVID-19 virus, as well as substantial population has received one dose, and a reasonable population has received the second dose as well. And we cannot forget that there has been a very high number of persons who have had been infected in addition to being vaccinated. So infection, vaccination, high seroprevalence shall protect us from the third wave being very, very high. It most probably will not be as high as the second wave, number one. Even if there are cases, the health system development which has occurred, especially the development of oxygen supplies and its logistics, and also creation of ICU beds across the country, strengthening of intensive care facilities across the healthcare facilities in the country during the last 3-4 months has been substantive. So India is better prepared. So I feel the third wave, even if it occurs, will have reasonably low impact in terms of death and hospitalization. So we should continue our guard. We should continue to practice our work in well-ventilated spaces, and also use social distancing and mask as possible, as much as possible. That should be the strategy at the moment.
In fact, now the pandemic in India, it is now becoming endemic because of infection and vaccination. And although the numbers may be less in the third wave and the intensity will also be less, but everything depends upon the individual immunity, individual resistance and resilience.
Yes.
So we have to be careful about ourselves, especially keep doing all sort of things which can improve our immunity, means physical, psychological, have good nutritious diet, take all the norms which are the social, like social distancing, masking, that everything has to continue till this R0 is below 1 for a long time, and that can only protect us. Otherwise, we will again go into the fourth wave as the Eastern Europe is going on. So this will fluctuate, and it is a dynamic situation. We keep on deliberating.
Very rightly. In fact, when you mention, Dr. Sandeep, about endemicity, all viruses do become endemic in the process. But we must not forget that at the moment, pandemic has not been declared as non-pandemic globally by the WHO, though emergency committee met for international health regulation about 2 days back. That's part one. If we have to open international travel in a measured way, like we are doing now, and from November first week, we will have more opening of the international travel, we should be actually seeing the impact at that time. Endemicity will happen when we are exposed to international traveling passengers, because the simple reason that variants of concern keep evolving. And recently in UK, there have been further variants detected for the Delta variant, which are of importance. So that also will have its impact. Endemicity is a process. The process is on. With what pace it will establish itself as an endemic disease or infection, we have to watch. But we must not forget, pandemic of COVID-19 is very much there.
Yeah. So I think it's almost 8:43, almost 2.5 hours of deliberation on both the topics, and this was a good scientific session on the eve of 75th diamond issue of our ENOCH DigiConnect webinar and the 40th Ruby issue of our COVID Epid updates. And we will continue with our efforts to educate our colleagues and get ourselves educated so that we can take care of others. I think, sir, with this, I should conclude the session. And thank you all very much. Thank you for sparing your valuable time. You can always visit our YouTube channel, ENOCH DigiConnect webinar. You can subscribe it and you can have a look on all the previous sessions. They are all reposited over there. So this is a good repository for everyone to go and refer to it at a later time at your leisure. Thank you very much. Thank you, sir.